not only were we struggling with the huge number of patients, I really had fear that our staff, you guys, nurses, technicians, that we're all going to be sick and not be able to do our jobs, and that some of us could have died, and unfortunately, some of us did die.
I have props for this.
Props.
Yeah, props. Yeah, let me put my props on.
Okay.
Put this on first.
I thought you were going to hold the book up to your face.
Oh, wait, it's coming. It's coming. So
he's very good with this stuff. There you go.
Here you go. Can you see the book? Can you see that handsome face?
Yeah.
Dr. Saggar is pretty big mad about not being on the cover. So
I got to be in the book signing. I'm okay.
And you have a quote in the book.
I have a quote. Although in retrospect, I would have said something more profound, I think, if I had.
Okay, but you could either be the guy with the looks or the guy with the brain.
Or in our case, both. But that's in our podcast case.
Ladies and gentlemen, that's the sweet sounding voice of Dr. Suraj Saggar. I am Dr. Clinton Coleman. Welcome back to Recommended Daily Dose. Now, if you're listening or watching, please make sure you subscribe, rate, and review. We have the guest of all guests. You're looking at him in his dapper outfit.
It's a sight to behold.
Adam Jarrett, Executive Vice President and Chief Medical Officer at Holy Name Medical Center in Teaneck, New Jersey. And if you didn't see that cover, author of this fabulous book, In the Time of COVID, One Hospital Struggle and Triumph, now available on Amazon. Go get one. It's also available on rxdailydose.com. So please go cop that book. As the young kids would say, cop it or buy it or purchase it. It's a great holiday gift, by the way. I want to start off by reading the back because it's such a tour de force, but I just want to, the first quote you have is great. Yeah. So it says, Dr. Adam Jarrett weaves a gripping tale from the front lines of the COVID pandemic and describes how a resilient staff responded without a playbook to care for a tsunami of critically ill patients. Whoa, we can stop it there, actually. How about that?
There's a lot going on in that one quote. So Adam, welcome for joining us today. Thank you,
gentlemen. I really appreciate you letting me share your podcast.
Awesome.
It's your world. We're just living in it, so.
Yeah, we want to get into your book, your inspiration, why you decided to write it. So I guess start off with that. Why you decided to write this amazing book?
So, well, thank you for saying that it's amazing. I appreciate that. So I was actually at a socially distant event in a friend's backyard. My co-author, Paul Rosengren, someone that I've known for years. And as doctors tend to do in a HIPAA compliant way, I was telling stories of COVID and they were, about patient issues, about the kind of things the hospital was doing. And he said to me, "Oh my goodness, Adam, there is a book here." And I said, "Nah, Paul, come on. I don't know whether there's a book and who has time to write a book."
Right.
He said, "Well, Adam, look, I write. I love to write. Paul's a very good writer. He's a very smart guy." And he convinced me at that event that I should spend 2 or 3 hours with him one afternoon a week for a month, one evening a week for a month. And so he agreed to feed me, and we met in his backyard for 2 or 3 hours. I think it was every Tuesday evening and maybe an occasional Saturday or Sunday afternoon for about a month. Right. And he wrote the first chapter after I think the first 2-3 weeks, and he said, "What do you think?" And I said, "Oh, it's intriguing." And then he said, "Well, why don't you take a stab at this chapter?" So I wrote a big chunk of the chapter on death. And I actually wrote more than I thought I was going to write. I really thought I'd meet with Paul a couple hours, a couple times a week, and he would write the book, and I would say, "Great, we wrote a book together." But I ended up writing quite a bit more of it. I'd like to say that I wrote 50% of it, and he wrote 50% of it, although never would have happened without him. He really motivated me to do it. And then we just started having conversations, and some conversations turned into stories in the book, and others did not. I wanted to do 2 things. Number one, I wanted people both in healthcare and out of healthcare to understand the remarkable job that Holy Name did, because I really felt like we did something special during the first wave. And I think a lot of that has to do with the kind of hospital we are. And then I also, being a primary care doctor by training and being someone who likes to explain things to patients in ways that they can understand it, I also wanted to write a book that non-medical people could understand the realities of COVID, the realities of testing, the realities of treatment. And I like to think I accomplished that. I think it's a book that non-medical people can sit down and read and walk away with an understanding of what Holy Name did and the realities of COVID, especially during the first wave. And at least the handful of physicians who read it told me they found it intriguing as well, although certainly this book is not geared towards them.
I'm sure it's more than just a handful, right? Because I understand you are ranking very high currently on the Amazon chart for respiratory diseases. I think we should let everyone know that you're currently #1 in that category.
Well, you know what? I'm not #1 anymore. When we spoke a couple days ago, I was #1.
Who overtook you? That's unbelievable. Who overtook you?
Yeah. I think being #1 in a specific subcategory is a very, 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 very small accomplishment. But we were excited to see that.
Sure.
And we hope that people are interested enough to give the book a shot. It's an easy read. I think it's a relatively quick read. Sure. And I think you walk away knowing a little bit more about COVID.
And I like what you said about the tsunami, which indeed it was, right, Clinton? We all lived it, but certainly tsunami. But I like the idea of unscripted, because it truly was unscripted, right? Something we never heard about before, quite frankly, December 31st of 2019. But before we dive into the book, I'm just a little interested in the process. Is this something you guys wrote linearly, or did you, in a linear fashion, or did you just kind of take thoughts, experiences as they came to you?
The first time we sat down, we tried to come up with 10 or 12 ideas. And then we said we'd write a chapter about those 10 or 12 ideas. And so it was not linear. And of those 10 or 12 ideas, probably only 5 or 6 of them got into the book. And then as we're writing, another 5 or 6 ideas came up. And we didn't initially, there's a whole chapter about HIV and AIDS and comparing and contrasting not only the diseases to some degree, but my experiences, because I did my internal medicine training really right in the middle of that pandemic. And that was not something we initially thought we were going to write about, but as I'm telling stories, it just came about. And then we move things around. The editing process is really fascinating, right? Something I've never done for an entire book. So I think the first chapter ended up not being the first chapter. So when Paul wrote that first chapter and I said, oh, that's intriguing, I think that actually ended up being the second chapter. So the whole editing process was fascinating, and it was not linear. It was really more subject-based, topic-based. And I knew that I wanted to do the chapter on testing, because I think that there's a lack of understanding in healthcare about the reality of how doctors should and do use testing. And I thought it was an opportunity to explain that. And that was particularly crucial as it relates to COVID, because the testing, especially in the beginning, was not only not present, but not particularly accurate. And so I like talking about that. I couldn't resist talking about what happened at the White House and the garden party. And I used that to talk about testing, because I think the White House, appropriately touted that they were testing everyone, and therefore they thought they were safe.
Right.
And I think that made the point that testing in of itself does not keep people safe. It is a piece of the puzzle. It's like we couldn't resist writing a chapter that started with that, because I think it tells part of the story. And I wanted to tell a chapter about the people, right?
Yeah.
Not just our patients, but our Holy Name staff. I mean, we lost another staff member in the last couple of days.
Right. Yeah.
And the impact that has obviously on their family, but also on the whole Holy Name community. And I thought that was a chance to really bring this disease home, not just for people here at Holy Name, but everywhere.
Did you find it difficult to tell so many different perspectives? You mentioned the HIV epidemic, but you were actually as on the front lines treating patients. This is like you're the head of the hospital, dealing, with patients and administration and things like that. Was that hard to capture that different type of perspective?
Well, it wasn't hard talking about it, right? But I do think
You still
that,
lived it, yes.
yeah, but I don't know whether any book, um, and not being a trained writer, and to
Right.
be frank, Paul also not being a trained writer, although he's certainly a better writer than I am.
Right.
I don't know how you can take the experience we had, because you guys lived it. I saw you guys every day. You were there. You were on the front lines much more than I was. I don't know how you could possibly take that experience and put it into words that do it justice. So we tried.
Right.
I do know that people have said to me that it brought a tear to their eye, or people have said to me that they hear my voice, people I know. That means a lot to me, that people have said, I hear you, and it makes me smile because I know what you're talking about.
For me, it was very surreal because I remember like when you laid out the dates. Like I remember being on call one weekend, maybe the first weekend in
Sure.
March, and it was maybe like 6 patients. And then the next weekend I came back, the hospital was almost full. It was just so surreal reliving it. And now you forget all those details because it was such, I don't know if it's post-traumatic or what. It's just like a fog. It seems like it happened years ago. So I don't know if you can speak on that. I'm glad you captured it. That's what I'm saying.
Well, thank you. I hope I did.
Sure.
The thing that I recall most, and I don't know whether I hope I captured this. I remember probably around the second or third week. So, towards the end of March, I remember really feeling like we were going to turn into a hospital that I could not conceive, right?
Yeah.
I really had visions of so many doctors, so many nurses, so many technicians being sick and not being able to take care of our patients. I mean, to me, that was what had the most impact on me until we lost actual staff members. That obviously had even a greater impact. But I really had a vision of a completely different healthcare system, a completely different hospital, because not only were we struggling with the huge number of patients, I really had fear that our staff, you guys, nurses, technicians, that we're all going to be sick and not be able to do our jobs, and that some of us could have died, and unfortunately, some of us did die.
Yeah.
Amazingly, and I think a lot of it was because of the good work that the Holy Name team did. Very few clinicians got sick. Not a single critical care doctor got sick. Only one infectious disease doctor got sick. Our critical care nurses, a handful of them got sick, but it was not overwhelming. A couple of our ED doctors got sick, but they got sick early on when we were not being as careful because we didn't know we needed to be as careful. And so once I realized that we were going to be okay from a staffing perspective, and okay doesn't mean it was going to be business as usual. But once I realized that there wasn't going to be patients who couldn't get cared for, or gurneys lined up in the emergency room, or patients not getting just the basic care that they needed, it didn't become not stressful, but it became a whole lot less stressful from my perspective. Now, whether that became less stressful for you guys who are still on the front line, I don't know. Probably not, right? But
I think certainly in all of us, whether we're physicians, nurses, administration, you kind of get into a zone where you have this adrenaline pumping, and every day you're just moving forward.
Yeah.
And I think to speak to your point, once we knew we were protected, PPE was not an issue, supply chain, and you talk about this, I think we powered on as we had to, and as we have no choice. And as you mentioned at your book signing, this time of COVID is not over, and we're experiencing it again. So I think it's very good that you acknowledge that. But we take that experience that you have so eloquently written about and now apply it to our current situation.
Yeah, I mean, the current situation is very different, right?
Sure.
But I am still worried about staff. I'm not worried about staff now so much because I think they're going to get infected at the hospital, because we're not seeing that, thank goodness. I'm worried about staff because people are trying to live somewhat of a normal life, and there's so much disease in the community now that we're seeing staff every day who are getting infected in the community and then having to be out. But it's not as overwhelming in terms, you guys know, in terms of the number of patients. The other thing that's worth talking about is Mike being out, right? So, our CEO was out for about 3 weeks with COVID early on. The book talks about that quite a bit. And that was a fascinating experience for me because I was kind of in charge, right, by default. And that was interesting for me.
I thought I
Not
was
something.
next in line.
No, John Poole,
I did,
our president of medical staff, tells me that he's next in line.
oh, I didn't get that memo then
So
because I
it's like
was.
the president of the United States, vice president, speaker of the House type of thing.
Oh,
Well,
I'm
I think
Lindsey
it goes
Graham.
down to the treasurer. Who's the treasurer of the medical staff? There you go.
See?
He's ahead of
See?
me.
I think he is.
What by quite a bit, by quite a bit, to be frank.
So that was fascinating. And in the beginning, when Mike first went out, he was well enough that we talked multiple times throughout the
Yes.
day. But ultimately, I mean, and thank goodness he never got sick enough to be in the hospital. But ultimately, he was so out of it. He kind of said, "Okay, Adam, I trust you. Do what needs to get done."
Right.
And that, particularly in a time of incredible stress for the entire organization, was a challenge. And I wish Mike was with us the whole time. But I think we got through it.
No, Adam, something very similar happens on our podcast. Oftentimes, I
we
have to
go.
take over for
Here we
him
go.
as well when he is either napping or doing his extracurricular activity. So I can understand how you feel, maybe to a lesser degree. But I oftentimes feel like I'm running things around here, at least in our little podcast.
Okay, but what that means is that Dr. Coleman is the CEO of the podcast, and he's really in
Ah,
charge, and you're just a number two that
Number two.
happens to be there to support him.
he'll always be number two.
I don't mind being the worker bee. It's okay.
Okay.
It's fine. It's fine. As long as I'm the face of the next book, it's okay. But
No, there's not a chance you're the face of the next.
oh,
Ha!
all right. That was a little comic interlude. For me, Adam, I have to ask you. You bring in the stories about staff, holy name family. How did the families of some of the, especially the nurses that may have been mentioned, how did they take to it, or how did you approach that very sensitive topic?
Yeah, so Paul and I talked a lot about this.
Sure.
Do we not tell those stories? Do we change names but tell the stories and adjust them so they're not recognizable? And Paul appropriately said to me, it's not the same book unless we tell the stories. It's not the same book unless we tell them the way they truly happened. What do you think about approaching people and asking for their permission?
Right.
So everyone who's in the book, whether they're a patient or a family member of a patient, I sat down with and I said, look, I'm writing a book. Don't know whether it's going to sell, and it's not really about that at this point. It's about memorializing what happened here at Holy Name, and what happened to you and your family was a huge part of that story. Are you okay with me telling your brother's story? Are you
Right.
okay with me telling your husband's story? And across the board, they all said yes. And then across the board, I actually showed them, not the earliest edits, but close to final edits, and literally got their. I didn't put anything in writing. I didn't think I needed to do that because these are all factual stories, right? But I got an okay from all of them to share their stories, and then appropriately, the book is in memory of all the people that we lost at Holy Name,
Wow.
and more specifically, our staff members or family members of our staff members. So across the board, they were all very supportive. They were not easy conversations for me, so they must have been very difficult conversations. I mean, I think the story that's most amazing is the two nurses and their husbands.
Yes.
Right?
Yes.
So it's two nurses who've been here at Holy Name for quite a while, whose husbands, about the same time, were in the hospital with COVID. Both of them became critically ill, and both of them got to the point where further aggressive care was futile, and the nurses were approached by the care team, and the nurses made the brave but appropriate decision to take their husbands off of life support and allowed them to die a natural, more comfortable death. And the nurses didn't miss a day of work.
No.
Yeah.
It just, and I actually knew these nurses, but didn't know them well enough to,
Right.
when I brought them in, tears and, what can you say, right? And that's why the book doesn't do it justice. It can't.
Well, I tell you what,
And I
Adam,
think,
it's testament.
hey, sir, can I ask a question, sir? I mean,
Of
I know
course,
you
I
guys.
just want to say, to tag it. I'm gonna let you speak at will.
Thank you.
It's Adam. I'm particularly very good friends with one of them, and I was, involved with the care of her husband. I will tell you, it was amazing to me that when he was care was withdrawn, out of the ICU, they wanted the husband to come to the floor, the sixth floor to be exact, and the entire Holy Name family, all the nurses there, all came in, and it was really, I think, just a testament, really a beautiful thing that they all came in at midnight, 1 o'clock, so that she would not be alone when her husband ultimately succumbed. So it was a beautiful moment. I know she's mentioned to me that she's very appreciative of the fact that you mentioned it's almost like therapeutic for her. And it basically giving that importance of and recognizing what happened.
Yeah.
Yeah, just to tag on, I think what you said as far as important, I think it's so vital to capture the humanity because, if you just watch TV, you see numbers and, 2,000 people died today and all that. It has no humanity. And COVID, I think, is unique because it's such an isolating disease, right? We really didn't see that much with any other epidemic that family members couldn't see their loved ones, and you just felt so isolated. And it's that emotional problem that we had to face. So I think it's capturing that is really difficult, but I think it's very important that we relay that message to the audience.
It's also I find random, right? I mean, and I don't know if I made this point as well as I wanted to in the book. I mean, you literally could be walking down the street one day and you're fine. Right. And then in 2 weeks you could be dying in an ICU with COVID. Right. And are there other diseases that can do that? Yeah, but not really. Right. I mean, I try to draw some parallels to AIDS a little bit. And I guess you're walking down the street one day and 2 weeks later you get your diagnosis of cancer. So it's, it changes your life. But it's so random. Right. And unfortunately, we're seeing people who don't think of themselves as being chronically ill.
Or high risk. Yeah.
Right. They don't think of themselves as high risk. They're 15, 20 pounds overweight. They know that's a little bit of an issue, but they don't think of themselves as sick.
Yeah.
And that's just the reality of this disease. And then, they get a little bit of a runny nose, and within 3-4 days, they're acutely ill. And then some of them, thank God, a very small percentage of them, but some of them go on and die. It's just the numbers don't do it justice, Clenton. You're right.
Yeah.
It don't do it justice.
That's why it's so important to humanize. I mean, this because, like you said, there's still a disconnect, I feel, and we've talked about this on our own podcast and before, of what we see as physicians and frontline workers and working in the hospital, and what other people may see that it's not my problem, it's someone else's problem. As we know, this is a misinformation age in this pandemic. So I think things like your book really that humanize. Do more so, they really are still educating, and like you said, in a manner that everyone can understand, so people can truly understand the impact of this disease. It's not something you see in the news. It's not a political issue, right? This is a equal opportunity, bringer of death and destruction, and you did an excellent job, portraying that.
So we're talking with Dr. Adam Jarrett, author of The Amazing in the Time of COVID: One's Hospital Struggles and Triumphs. Which I thought was really interesting part of your book. You talk about all the innovations that the hospital did. There's a quote that you mentioned: "Necessity is the mother of all invention." Can you tell us about some of the cool things that you guys did?
Yeah, well, yeah. I mean, I got to give a lot of credit to Steve Mosser, who's our vice president of facilities, as really being the mastermind for some of this. So early on, the CDC. I think appropriately pointed out that this is an aerosolized disease, meaning that all patients who are tested and treated should have that done in a negative pressure environment to minimize the risk to people outside of the room that patient and caregiver's in. The CDC has waffled on that a little bit.
They waffle a lot. I mean, we don't want to get into the waffling, but
they do waffle a lot. So we can talk about that later. But we decided, based on, I think, good clinical evidence, that we should do everything we can to treat patients in negative pressure. And Steve really came into my office one day and said, Adam, we could do this. I can build hundreds of negative pressure rooms. It doesn't take that much.
And what's his background?
Interesting. So Steve was trained as a merchant marine.
Oh,
and
me too. I'm joking.
Yeah. So he was in an environment for years where he'd be out on a ship with 3 or 4 guys, and something would break, and he'd have to figure out how to fix it with whatever he had. It's almost like the Apollo. I forget what the movie is. One of the Apollo movies.
Apollo. I know what you mean. Where they had to make the scrubber to keep the oxygen, get rid of the carbon.
And the NASA guys collect everything they have on the ship and they pour it on the desk and say, okay, here's what we have to make, and we'll figure it out on the ground, so the guys up in space can utilize that. That was sort of Steve's mentality. So, Steve, we literally went to 3 states to get the equipment we needed to create negative pressure rooms. We ended up creating over 260 negative pressure rooms. And there's an interesting graph in the book that shows the number of COVID patients and the number of negative pressure rooms. And we literally stayed hours ahead of the curve, with Steve constantly building out negative pressure rooms. On a typical day, I'd walk up to the ICU, and the construction guys would say, okay, do you want us to finish ICU negative pressure, or do you want us to go up onto the medical floor? Where do you need more negative pressure? And then a couple hours later, I might shift them again. And we literally, kept hours ahead of where we needed to be with negative pressure. And then I think this was the most impressive thing that Steve did. In the early days of this, testing was slow, right? In the early days, there was no testing. And then when testing came out,
there was no testing, or we had to get permission to test.
We had to get permission.
Yeah. And it took a week.
In the very early days, we had to get permission. And the guidelines for what you needed to get permission for were not good. They were not good, right? And then once we could get tests, it still took 5 to 7 days. And so now you have a patient who you don't really know has COVID, or 2 patients that you don't really know have COVID. You think they do, but you would feel a lot better if you had a test result. And now you're running out of rooms, so you don't want to put those patients in one room together, because what if one of them is really positive and one of them is negative? And so Steve came up with this concept of an isopod, which is essentially a single negative pressure chamber that sits over the patient. I was very skeptical. I was like, Steve, this is never going to work, right? You can't create a negative pressure environment like that. And he did, and it worked. And the book talks about it, and it allowed us to not get overwhelmed, because we could keep 2 patients who we thought likely had COVID, but we didn't have test results back, in one room, because they would each be in their pod. And the pod had some problems. They were heavy and they were difficult to work around. And we're not using them now because testing results come back so quick that we don't need them now. We have them just in case. But in the first month of this, in March, they were remarkable, right? They made a huge difference.
Now, as because obviously your humanizing experience, part of our job is to humanize you. So just as a side note, as a Star Trekkie, self-admitted Star Trekkie, did you find this
I'm going to check out
satisfying to talk about this in your chapter?
So let me know when you guys are done.
So I described the isopods to my co-author, Paul Rosengren, and he said to me, that's like the cone of silence from Get Smart.
That's right.
Right.
That's right.
And I said, well, not exactly. He said, yeah, but it'll help people understand it. And so he put that in. My daughter, who helped us copy edit the thing, did a really good job helping us copy edit it, hated that part of the book and said, no one's going to understand what the Get Smart cone of silence is. So do you guys know what that is?
I have no idea.
Again,
I was born in 78.
Younger than you. I do, because I'm a well-read person. I'm pretty sure Clinton does not.
Right. So my daughter said no one's going to understand that. So Clinton, you got to go home tonight and Hulu Get Smart.
Is it black and white or is it color?
I think it's in color. I think it's in color. But she hated that. And then there was that. Then there was the Star Trek reference. She loved that. So she said, Dad, keep the Star Trek reference in, because that's great. And because you really are more of a Star Trek guy than a Cone of Silence guy.
True.
And okay, but the really good news is the first 10 people who read the book for us specifically pointed out they loved the Cone of Silence thing. So I was able to go to my daughter and say, you were wrong. That was great. That was great.
But Star Trek still was very, I think, very cool. And I think if you could have put in a Lord of the Rings reference somehow, maybe in the sequel, then that would really complete.
Well, maybe there'll be a trilogy.
Ah, see, I love that. I love it.
I hope not. I mean, for the book, yes, but for the pandemic,
for the world,
I think there's enough material for a trilogy.
Right.
Yeah. Yeah, and maybe even we'll have to go back and do The Hobbit, like do like a.
Right, you lost Coleman, but you've got me. I'm in all the way, as you know, because I'll dress up for it in my Hobbit, my Middle Earth gear.
That's a scary thought.
As an administrator in the hospital, as a chief medical officer, were there times where you disagreed with the CDC or found it difficult to run a hospital You already mentioned the example of testing, and that was a
Right.
fiasco. Recommendations of testing asymptomatic patients, and also the negative pressure issues, whether it's airborne
Yeah.
droplets. How were you able to function when you didn't agree with some recommendations?
Well, so here's the really good news, right? The really good news is that Mike, our CEO, is not a big believer in just blindly accepting guidelines, right? Because
Right.
guidelines are just that, they're guidelines. We know they change. We know they changed, for routine recommendations in day-to-day healthcare, let
Right.
alone in the middle of a pandemic with a disease we know nothing about. So Mike's, edict is don't just accept what the CDC says. Don't break any laws, Adam, right? If you have to bend some rules, that's okay, but don't break
Right.
any laws. But don't just blindly follow the guidelines. And I don't want to be critical of the CDC. I think that they made the best recommendations they could make, knowing what they know or knew. But I have to tell you, I don't think anyone knew better than healthcare workers and hospitals that were on the front line.
Yeah.
And I think that they were wrong sometimes. And
Yeah.
I think they're wrong about negative pressure now. They still have come out not saying they've waffled and now say that this disease is spread by aerosol and droplet,
Right.
but they don't specifically say, and so therefore it should be treated in negative pressure. I don't understand that at all. Right? I don't understand how you can say a disease is aerosolized like TB,
Right.
right? And not recommend it be treated with negative pressure. That I'm still confused by. The only thing I can think of is they're concerned about the ability
Uh,
for hospitals to create 260 negative pressure rooms like we did.
I agree 100%. I think you're absolutely right. They've said that, hey, it's not spread so much by contact. It's probably mostly droplet. But even in the ID literature, they'll say could be aerosolization. But you're right. I think they stopped short of making those mandates because they're afraid or ascertain that the ability to make enough negative pressure rooms is just will be exceeded by the patient onslaught.
But I tell you, Suraj, it wasn't that hard.
Yeah.
I mean, the three of us couldn't
Sure.
do it, but Steve
Right.
Mosser and his team knocked out windows, cut holes in pieces of plywood, got HVAC pipe
Right.
ducts, hooked it up to a fan and a HEPA filter. It wasn't that hard. So I'm a little. I think that's the thing that's most frustrating me in terms of what the CDC where they stand now. And I don't want to be critical. They're very smart people. I think that Anthony Fauci did an amazing. He's not part of the CDC, but I
Sure.
think in a very difficult situation, walked a very fine line that he had to walk through this pandemic, and I think he did an amazing job in a very difficult situation. And these people are brilliant and smart, but they're not always on the front line,
Mhm.
And I was a little frustrated with the pop-up hospitals. I talk about that in the book as well. And I don't understand why the pop-up hospitals became what they were. And I understand that there might be a need for a pop-up hospital, but I don't think that we did it as a nation and are still doing it as a nation as well as we could have. I think that if we design pop-up facilities, and I talk about this in the book, potentially serve as quarantine facilities for patients who are well
Right.
enough to go home but can't go home, we would have done a whole lot better job at
Mhm.
decompressing the hospitals as compared to using pop-up hospitals. Initially, they were designed to
Right.
treat non-COVID patients, and the reality is those hospitals were just not equipped to take care of non-COVID patients because
Yeah.
taking care of patients today is complex. And then they
I think
decided
I
to
think you
use them. Again, I'm sorry.
No, but you're absolutely. I just want to interlude. Like, I think a lot of those pop-up hospitals were not utilized, and I remember and I'm forgetting the name of the ship that came into New York Harbor and left, I think after a few days, and was very vastly underutilized. So I think it's just, again, a reflection, as you mentioned, of the lack of central leadership, especially early on. But I wanted to ask, because you've been, and the administration here has been very open and transparent all along about our experience, about what was happening. Maybe more so than other places, especially in northern New Jersey. I just wonder if that was something that was on purpose, that was just deliberate, or was that something that just kind of happened?
I think it's the philosophy of this place, right? I
Mm.
think that, we know who we are. We know that transparency is almost always, if not always, better.
Sure.
And so that's just the way we function. We don't always get it right, right? Especially in the middle of, brand new pandemic. But it doesn't do any good to not admit what you know, admit what you don't know, and if you don't get something right, learn from it and move on. I talk about that in the book with masks, right? We did not do a good job as a healthcare community as it relates to masks early on. I was one of the people. I remember having a conversation with my wife. You don't need to wear a mask. Adam, why wouldn't I wear a mask? Why wouldn't people wear masks? I said, because masks don't really work in this situation. I couldn't have been more wrong. And we just need to admit when we get something wrong and then move on and not dwell on it. Because we're going to be wrong as it relates to new diseases. And that's where we were. So yeah, I don't think we specifically said, let's be transparent as it relates to COVID. I think that's just the philosophy of this place in general.
Is there anything that you would do different as far as managing the hospital in retrospect?
Wow, that's a great question.
Hey, I'm the Barbara Walters of podcasting.
Wow, yeah, Barbara Wawa.
Barbara
That's
Wawa.
why he gets paid nothing.
Are you too young to even know the Barbara Wawa reference?
Yeah, of course. That's
Saturday
from
Night Live. Saturday Night Live. I remember.
Good, very good. What would I have done differently? So I had some very contentious conversations with doctors early on about mask wearing. Doctors who were wearing masks and were smarter than me about the need to wear masks. So I had at least 3 or 4 contentious conversations where I said to the doctors, there's no reason to wear a mask outside of a patient room, and you're setting a bad example because masks are in limited supply, and you need to function like a leader and not wear a mask. Boy, was I wrong. And not only was I wrong, I was tough about being wrong. I regret those conversations a lot because those doctors were right. Once we realized that the risk of getting COVID for staff was not from patients but from each other, and those doctors figured that out before I did, boy, I would take that back in a second, and I would have put masks on everyone really early. I think I would have, when we initially planned, we thought 6 to 10 patients in the ED. We thought that's all we were going to have. So in retrospect, I would have gone back, and then it wouldn't have been such a race to build out negative pressure rooms. I would have done that, weeks or months ahead of time. I could talk about some therapeutics. I mean, we really pushed some of the interleukin-6 drugs, right? They seem to have worked, but the evidence is now pretty clear that they don't work, right? So, that's an issue.
But but at the same time, we have been, I think, it's a good place to as we wrap up, we have been at the forefront of therapeutics, right? Through our Institute of Clinical Research, through your very strong ID department, no names will be mentioned. I think
a very strong leader. Very strong infectious disease leader.
With a shiny head.
Very shiny head. But we have been, in fact, we are now playing with the big boys, so to speak, or big girls, however you want to put it.
I think
in terms of the clinical trials we have, the things that we have to offer. I mean, I think that has really put us to the forefront.
Yeah, we have 7 active COVID trials. I think that's more than anyone else in the region. We are enrolling patients every day. We were the first hospital, I don't know whether you guys have talked about this on the podcast, we were the first hospital in the world to give a monoclonal antibody to a patient outside of a trial. No, in a trial. We were the first.
In a trial. It was done by a ID doctor with a shiny head.
Continue. Right? That's incredible. The drug that the president got through emergency use, we were the first hospital in the world. We were the first hospital in the country to use placental stem cells. Now, the jury's still out on placental stem cells, so we think we saw a good response from it, but the jury's still out. I think the jury is a little bit further along on monoclonal antibodies. We had patients who were transferred in from the entire tri-state area for trials. We had patients who were transferred in from hospitals 7 miles from here because we had access to medication and treatment that they did not have. So, I feel and a lot of that has to do with our chief of infectious disease. I won't mention his name, and our head of research, Dr. Barkama, who really did the hard work of getting manufacturers to understand that we had the ability to get patients these medications in a trial setting and do it in an efficient way so they could get the information they needed, right? Because what they care about is getting enough patients enrolled so they can prove that their medicine hopefully works. And we showed them that we do that actually quite well, and in fact, in some cases, better than big fancy academic places. because of our size allows us to be more nimble.
I have another tough question. I
Yeah.
don't know if you're ready for this one. What would you say the happy ending would be in the book? Like, if you could tie it up, because I want to leave everybody on a good note.
Okay. So as you guys learn, I don't answer a question, with a few words. I'm as long-winded as you guys are. So when we were writing, right, literally up till the last 3 or 4 weeks of writing, I thought the happy ending might be that there might not be a second wave in northern New Jersey. I foolishly convinced myself that there was enough immunity out there. There was something about what happened in northern New Jersey and the New York City area
Right.
that we were hit so hard there wasn't going to be this second wave, and that we would continue to see low levels of disease, but it wasn't going to be the second wave. So I actually was cautiously optimistic that that might be the happy ending, and obviously I was wrong. In fact, we were rewriting the book literally up until our deadline that we had, because things were changing on the ground so much. Now, the happy ending is that the vaccine is easily dispersed, that the American people and the people around the world are willing to take it. I don't think it's going to be as effective as the initial studies show at 90, 95%, but that's okay. Even if it's 50, 60, 70% effective, the happy ending is that, unfortunately, we got to get through this wave, which the vaccine's not going to help. And the unhappy part is we probably will lose another couple 100,000 Americans. So that's not happy. I think that the writing's already on the wall for that. But I do think the happy ending is that by middle of this summer, and I'd be curious what you guys think about this, that we are back in a life that is not a pandemic. COVID hasn't gone away, but that we're back to normal life, no masks, the economy and society being open.
Right.
And then, unfortunately, COVID becomes one of those diseases that you guys continue to see on an occasional basis,
Or
but
seasonal.
not in an overwhelming way, likely for years. So that's the realistic, mostly happy ending, mostly. I'm curious what you guys think.
I think the happy ending is the realization of the humanity of the doctors and the staff and the nurses and people in the hospital, because I think we may have gotten to a point in healthcare where it's just, factory working and, a concession line, and we really don't have that humanity. So, it's I think that camaraderie that, we saw and put light to, I think that is the silver lining. I think that's
Well,
my opinion.
that would be a better ending to the sequel book, right?
Okay, cool.
I hope you're right. I'm a little
Right.
skeptical, but I hope you're right. I know that medicine will never be the same. I know that I'll never be the same. I mean, I felt that way after the AIDS epidemic, and now I feel that way again.
Yeah.
I'll never be the same, and I don't think healthcare will be.
Well, I think these are all, important points you raised. I would say that, one thing is that this has exposed kind of the, unequal access to healthcare that we're seeing, because we know that certain lower socioeconomic and minority populations are unfairly being burdened by this disease. So hopefully, as we say, making lemonade out of lemons, this can bring to light these disparities and really, bring these to the discussion later, that we need to do a better job as physicians, as a healthcare system.
All right, so you guys answered that question much better than I did. I'm going to take both of those and put them in my next book. My answer was kind of boring. Your answer was good.
Who would play you in the movie version of this? That's my last and final question.
Okay, so I've been asked this before, and I have the person who I'd want to play me, and the person who probably should play me.
So Brad Pitt is unavailable. Okay.
So Brad Pitt is the person I want to play me, but I know that's not going to happen. So
Morgan
I'm
Freeman?
more likely going to get played by Jason Alexander.
Of Seinfeld fame, aka George.
I think that is more likely, my character. That's disappointing, but that's who I am. That's not who I am as a person. But
so you're saying you're more of a Costanza, less of a Seinfeld, is that right?
No, well, I think that the actor physically can portray me better. and I think he's a talented enough actor that it's not George, but Jason Alexander as an actor who could.
I got it. For me, he'll always be George. I think he'll always be Costanza, but
then now you guys are in the book, so are you playing yourselves? Because
No, I think I'm gonna have. I think Morgan
The Rock.
Freeman will be playing Clinton, and for me, probably a Bollywood actor, du jour, will be playing me. For hopefully with a little bit more hair. So we'll have to wait and see. We're hoping for the movie to come out sometime soon.
Morgan Freeman, that's pretty impressive.
He'll do it for free. It's gonna be.
I was thinking maybe more Denzel.
See, that's what I thought.
Dr. Adam Jarrett, not only Chief Medical Officer, but author. We want to thank you so much for coming on today. So we can find it on Amazon, Kindle. Just tell us just before we go where readers, listeners can check you out.
So it's on Amazon and Kindle. In the Time of COVID is the title. If you type that in, it comes up. It's easily findable on Amazon. I'd love people to give it a shot. Love you to give me honest feedback, either in person or by writing a review. Makes a great holiday gift for people. This is really about trying to get the word out in terms of what Holy Name did. Great stocking stuffer.
That's the
it's
word.
just the right size. And Clinton's picture's on it. So I actually ripped the cover off and put it in a frame by my bed.
I need a blow up.
It's on my nightstand, but I have to turn it over because I can't wake up in the morning or go to sleep at night looking at Clinton's face. I just can't do it. So I turn it over.
Haunting you.
He is haunting me. Well, we want to thank Dr. Adam Jarrett, again, Chief Medical Officer, Holy Name Medical Center, author, runner, lover of all things Star Trek and Lord of the Rings. Thank you for your insight. Thank you for your leadership. We very much appreciate it. As always, I'm Dr. Suraj Saggar with Clinton Coleman, my co-host. Find us on Spotify, Apple, Stitcher, rxdailydose.com. Until next time, be well.